Good afternoon, and thank you for joining us here again and rocking with us today. You're watching us, we are the State of Black Health here on blackdoctor.org, and this is on Martin Luther King Day. We came up with this wonderful idea in partnership with the Rodham Institute at George Washington University. Got to give them a shout out for their partnership. It's been a wonderful partnership led by Dr. Gigi to put together the State of Black Health. And what we're doing today is a full day of panels talking about significant issues, health conditions that are impacting Black communities. And so we said, it's Martin Luther King Day. There's a lot of focus on moving forward and really coming together as a community. And so what is more important than to rally around as our health, right? And what's impacting our health and negatively impacting our health. And so we've got to do a better job. And so we put together these panels. So earlier, if you missed it, we did a wonderful panel on COVID, just really got real about COVID. We just finished a panel on breast cancer, which was phenomenal. So you could always go back and watch it on the Black Doctor page. That breast cancer panel was phenomenal, talked about what was triple negative and all these different things that are really important for Black women to understand about breast cancer screening. And now, our third panel, this is like the apex. We've got heart health, right? Because we understand that heart health and heart disease, number one killer of Black people. And so it's not COVID, or at least for now. And it's very, very important. And so because heart health is connected to so many health conditions that disproportionately impact our community, like diabetes, aka the sugar, like hypertension. All of these conditions are heart related. And so if we have those cholesterol, I can speak personally. I'm a person that has high cholesterol. My mother has high cholesterol. So I'm very, very concerned about my cholesterol level. That impacts your heart health. And so I'm here. I'm going to shut up because the panels are better than what I could do. So Dr. Gigi, how are you? How are you feeling? You've been rocking.
I feel great. I mean, I think that, I'm very proud of the ability to share the panels with so many talented African-American women and men, whether physicians or patients or advocates. It just goes to show you the wisdom and knowledge and experience and how deep it is. And we need to do better with our own health and well-being. And I think with COVID, everything is so COVID focused that we are forgetting to get those mammograms. We're forgetting to look at our blood pressure. And I can tell you, I've unfortunately diagnosed people at later stages of their disease. So I can't wait for this panel because I think we're going to get a lot of great information and I'm psyched. So let's bring on our panelists.
Absolutely, absolutely. So yeah, the first panelist we're going to bring on is your friend, and this is Dr. Reginald Robinson. So let's let you introduce Dr. Robinson.
So Dr. Reginald Robinson is a friend indeed. He is just an incredible cardiologist. He is also somebody that we've invited to share his experience and knowledge with middle and high school students to think about choosing a health career. And also he is now the regional director of the American Heart Association. And I may have gotten your titles wrong, but the important thing is that you're just an incredible cardiologist that's very involved and connected to the community. You see him wherever there's an event in the community. Dr. Robinson is there. So thank you for joining us. And tell me if I've missed anything in terms of your title.
All that stuff's not important, Gigi. Thank you for having me. She's one of my favorite people in the world too. She is quite humble and she's always out there and out there supporting 100%. So just thank you for having me.
Mutual Admiration Society here. Mr. Ellis.
And I love the fact that he's rocking an HBCU's shirt right now. So
that's right.
I like to say Morehouse made me a man and Howard made me a doctor.
Yeah,
absolutely.
And it's Martin Luther King holiday. So I thought I'd represent Morehouse today.
That's right.
Absolutely. Absolutely. So our next physician is Dr. Rachel Bond. She is some of everything. Like I mean, she's a board certified attending cardiologist in Arizona who's devoted her career to the treatment of heart disease through early detection, education, and prevention. There's a whole lot of other great things about Dr. Bond here, but for the brevity, I'm going to say this. Dr. Bond is a fellow of the American College of Cardiology and member of the American Society for Preventive Cardiology, Association of Black Cardiologists, and the American Heart Association, where she is a national spokesperson for the Go Red for Women campaign and sits on the board of directors. Welcome, Dr. Brown.
Thank you for having me, Alice and Dr. Gigi.
Next up, the next two people are people that just came across. I had the pleasure of meeting and interviewing earlier. One is the CEO of an organization called Women Heart, and she is wonderful at their advocate organization. She can tell you better than I can, but I did an interview with her and Shanta Collette a few months ago, and really just said after that interview, I said they were so impactful. And when I knew we were doing these panels, I said, I need y'all to come back because we're going to talk about heart health, and there are two people I need to come back. Shanta Collette is a survivor. She's had a stroke, and so she can speak to what it's like as a Black woman to have heart disease and have an issue and how that changed her life. And then Selena can talk about what it's like to be an advocate and the obstacles and roads and what they're really trying to do in terms of advocating for heart health, especially women's heart health. So I'm going to bring them both on. This is Selena Gore. How are you doing today? And then we've got Shanta Collette Carter-Williams. So thank you all for joining us. I think that's the entire panel. I think we got everybody. So we are here. We're good to go. So Dr. Gigi, you want to ask the first question to Dr. Robinson?
Yes, please. Dr. Robinson, kind of give us an idea. When we talk about heart disease, what really are we talking about? I mean, the heart is not just a muscle. Can you just basic 101 education about the heart and what is heart disease?
So the panel, the title of this panel, the ABCs of heart disease. So you can add the D, say ABCD. So if you think about A, atherosclerosis or plaque buildup in the heart, aneurysms, apnea, can include sleep apnea under the A. B, blood pressure. That's one of the most impactful medical conditions that affects, in particular, African-American population. When we move to the C, think about cholesterol, congestive heart failure, and D. Most people don't think about this as a cardiovascular disease, but diabetes. We consider that a cardiovascular risk equivalent. So if you have diabetes, that's just like having heart disease. And then we can add in, quote, poor circulation. You know, people say, oh, I have poor circulation, but that's a condition, something called peripheral arterial disease. And it's like the tree. If you have disease in the roots of the tree, you probably have it elsewhere. So that's one way of looking at your, quote, cardiovascular health. If you have a stroke, you're at higher risk of having a heart attack. If you have peripheral arterial disease, you're at higher risk of having a heart attack or a stroke. So it encompasses all of those different things and more.
So if you could also tell us about sort of the four systems in the heart. People tend to just think about the blood vessels that supply the heart. They don't know about the muscle and the valves and, you know, the blood vessel system. Can you tell us about that?
So if we're just looking specifically at the heart and you think about the plumbing of the heart, I like using analogies. So I talk to people in the office and say, if you have a 56-year-old house and you've been pouring grease down the pipes for, quote, 30 years, that's like your diabetes. And you cut that plumbing open, more than likely you'll see some issues in your plumbing. So that's the vascular issues from the heart, where it increases your risk of having a heart attack. The muscle, it's just like any other muscle. Think about doing a bench press. So when you do that, top number of your blood pressure is like when you're pushing the dumbbell up, the bottom number is when you're bringing the dumbbell down. Your heart can beat 10 to 20,000 times a day. So imagine your heart beating 10 to 20,000 times a day over 50, 60, 70 years against high blood pressure. What happens? Just like any other muscle, it has to compensate by getting thicker. And over time, you develop heart failure where that heart gets thicker, gets stiffer. And then over time, if you keep on putting that pressure on that heart with the higher blood pressures, the top number as well, what we call the systolic blood pressure, and the diastolic blood pressure, or the lower number, it continues to fail. And it's like stretching a balloon. So if you keep stretching the balloon, it loses its elasticity and doesn't have that kickback. So that's the later stages of congestive heart failure. The valves are like the doors in the heart. So The valves open and close. Again, they're opening and closing 10 to 20,000 times a day. They can become stiff, or what we call stenotic. Think of a balloon. If you press tight, you pinch the balloon and that air comes out. That air coming out is like the heart murmur. And that heart is the balloon trying to push that air out of the balloon through that tightening. So that pinch portion is the aortic valve. If you get a stiffness of that valve, you've seen commercials now, they're going direct to consumer with this procedure called TAVR. You see commercials about getting your stiff heart valve fixed without going to surgery. So you have 4 valves or 4 doors in the heart that open and close. Each one of them can become leaky or stiff. And then you have your electricity of the heart. You've seen the Eliquis and the Xarelto commercials and issues with stroke. We talk about atrial fibrillation or atrial flutter. Those are different electrical issues of the heart that can cause someone to have an increased risk of stroke. And then you have the bottom part of the heart, the electricity of the heart, where you see people on the TV or the movies and they pass out and you shock them. That's something called ventricular tachycardia or ventricular fibrillation, generally when you see someone being shocked. So you have your electricity, you have your plumbing, you have your muscle, and you have your valves or doors of the heart.
Wow, that is such an excellent description. And I should say we said ABC because we also wanted to talk about the other sponsor of this panel, which is the Association of Black Cardiologists. So
Absolutely.
that wasn't a coincidence of choosing that. Thank you, Dr. Robinson.
You know, Dr. Gigi, I want to take a turn and talk about the actual patient experience. So Chantaquilla, I want to bring you into this conversation because all of those things that Dr. Robinson is talking about are what can happen. But I want you to share your story about what did happen to you, and did you have any warning signs, or was it just at kind of a spur of the moment it happened, and then you had to figure out what to do after the fact?
Yeah, absolutely. It was really a roller coaster. So my experience started back in 2012, pretty much exercised, ate right. One day I was just on a treadmill and I started to feel a flutter of my heart. At that time, I let my nurse practitioner at my OBGYN know that I was having some fluttering while exercising. And she immediately sent me to a cardiologist. I went through a cardiologist. They couldn't give me a diagnosis other than exercise-induced arrhythmia, and just told me to monitor my heart. Wasn't any other extensive tests. I went from 2012 going back and forth to the hospital, complaining of chest pains, shortness of breath, a number of symptoms that were ignored. And in 2018, maybe a week, the week of June 19th, I was just experiencing just a number of symptoms, out of breath, just extremely fatigued. And that's where I had my first heart attack. I was admitted to the hospital. I was under the care of a cardiologist who basically just said that, you know, it was stress and it was related to my work. And I just needed to change some things. Symptoms increased, tried to do my best to change my habits and what I thought may have been causing the issues. And about 10 months later, while at work, just a day after I had been released from the cardiologist to go back to full activity, I collapsed at work and had a stroke. So it was a long period of things going on, but I did recognize something was going on with my body and did my best to try to articulate that to my doctor. But you know, it wasn't enough, and I'm thankful that I'm still here to talk to you all.
Dr. Bond, when you hear her story, what goes through your mind as a cardiologist? And you know, not saying that I'm not trying to review her cardiologist, but when you hear how that story plays out, what are you thinking?
That her story happens too often. It happens too often for women that look like her, that communities that look like her, most notably due to the age, due to the race, ethnicity, and more importantly, due to the gender. As it stands right now, we know that in the community, particularly Black women, over the age of 20 have 60% of cardiovascular disease. And yes, hypertension is leading the way when you think about the risk factors. But when anyone's coming in with signs or symptoms, as you very nicely described your symptoms of palpitations, that warrants further evaluation, that warrants doing testing, that also warrants taking a very extensive history, a history that allows us to determine what risk factors a patient may have that makes the likelihood of this coming from the heart more probable. So although I wish I can say that this is something that we hope we will see improvements in, we know that as it stands right now, women are typically less likely as aggressively treated, and unfortunately less, as a result, they're less likely underdiagnosed, or they're more likely underdiagnosed when it comes to cardiovascular health.
So are the symptoms different in women versus men?
So when we think about the classic symptoms of, let's say, a heart attack, you always think about sort of that picture in the movies where someone's clutching the center of their chest, where they may describe like an elephant is sitting on their chest. And that does actually commonly occur in women. It's about a third of the time when they may not feel those classic symptoms. And it's that third of the time that disproportionately occurs in more women than men, where they may feel actually no chest pain. They may feel shortness of breath. They may feel shoulder discomfort or jaw pain or indigestion, like their stomach is having an upset, as an example, or even a warning sign could be fatigue or tiredness. Just ongoing tiredness could be a red warning sign that there's definitely something going on, especially if it's ongoing despite getting a good amount of rest, especially if you have risk factors, which it's important that the audience understands what are those traditional risk factors that the general population has, but women have very specific risk factors as well that are important to acknowledge too.
Can I piggyback on something that I didn't want to go past that Miss Carter Williams mentioned? She mentioned stress. And a lot of times, particular men doctors may think, oh, it's in your head. But when you think about things that's being in your head, stress actually can kill. There's a syndrome called Takotsubo's cardiomyopathy, where in particular, under a stressful event, mostly in younger women, come in with a heart attack, every symptom of a heart attack, the chest pain. You take them to the cath lab and their arteries are completely open. Some of the theories are that there's a high amount of adrenaline that causes those arteries to spasm and a whole bunch of other things. We know we have the fight or flight response, and those things actually happen. They actually happen and cause some kind of impact down the line. So stress has a big impact on cardiovascular health, hypertension, acid reflux, but don't let any doctor tell you it's all in your mind. That's more than just stress itself. Just have them to test them and make them do their job when you go into their offices.
So let's bring in Selena, and I saw you shaking your head a couple of times when the doctors are talking, because this is what your organization directly deals with in terms of specifically with women and getting them to understand that the symptomology might be different, how it expresses is different, and then the education and how women are treated by the healthcare system. So kind of talk to what your organization does and how your role is between the patient and the healthcare provider.
Yeah, thank you so much, Alice. So I think the number one thing that we at Women Heart do is to enable women to be their own best advocates. And that's easier said than done. We know for sure that, as Dr. Bond has said, as Shanta Collette sort of gave us an example of, it's really, really challenging for women often to navigate the healthcare system because we want to take the word of the doctor. When they say to us, it's you're fine, maybe this is just an anxiety attack or a panic attack. I've had the experience as well of going into the ER with heart symptoms and being told that, you're fine, everything is normal, maybe it was just a panic attack. And I think that what Women Heart does and does really well is it provides women information like how different the symptoms may be in women who are experiencing a heart condition, to ensure that, as we just heard from the doctors, that we hold our healthcare providers to account for going through all the processes of running all of the battery of tests that you should run to do a complete cardiac workup. That's really, really important first and foremost. And the second thing is that Women Heart does really, really well in providing other women who are going through their heart journeys a community of women who've gone through it just like they have. And it turns out that that's really, really critical in their journey from surviving a heart attack to thriving with heart disease. And that's the journey that we at Women Heart really love to support women through.
One of the things that's definitely true is that not everybody gets offered the same opportunities or treatments, rather, when they're in the middle of a heart attack. And we know that there are even different stents that are used to open up a blockage, and how those stents are offered to Black people versus white people can be quite different. Dr. Robinson, can you comment about that? Because, you know, heart disease or any disease, especially when you're in the moment where you have to have a quick intervention, we may not know what to ask if it's a layperson. Can you help educate us?
So one of the things is, as you mentioned earlier on one of your other panel, that cardiovascular disease has been a leading cause of death probably since the last pandemic in 1918, when it was the other pandemic. And why is that? You know, we tend to focus mostly on how someone eats, what their activities of daily living are, but then you have to come and think about health equity or social determinants of health, how people live and work and play and pray, and how those things actually have a huge impact on cardiovascular outcomes. So I love to, quote this article by a guy named Elijah Wolfson. If you look up Time magazine article, it looks at how zip code predicts your life expectancy. And he models Washington, D.C., Chicago, and New York. And you hover over different zip codes and you can see probably a 10 to 20 year life expectancy from someone in Southeast D.C. as compared to someone in the upper Northwest quadrant. And looking at all the health indices that actually contributes to someone's lifestyle and outcome. So access to healthcare is still a leading area. So we're going to be talking about this for another 100 years unless we get legislators on board, policing, housing, environmental impact on overall health, not just cardiovascular health, but overall health and how we live and tackle some of those other factors.
Well, I want to just make a sad correction. In Washington, D.C., according to Uneven Opportunities, a person who lives in Georgetown, which is in Northwest, can expect to live on average 94 years. If a person lives in Anacostia or Southeast, that number goes down to 66 and a half years. So Washington, D.C., we actually have the biggest difference in life expectancy, almost 27 years. But I want to come back to the offering of the drug-eluting stents. And I'm going to just share with you a study that was done by one of our white cardiologists. Actually, you see him on CNN, Dr. Reiner. So he was convinced that what he does with his patients is that he offers the same excellent treatment to everybody. And he had the courage to actually look at his data. And what he found out is that he does not offer the best treatment to everybody. That he was more likely to offer what we call the drug-eluting stents to richer and wider groups of people. And as a result of that self-examination, he has actually changed his practice. And so that's why, I really support and endorse the Association of Black Cardiologists, because you can actually find Black cardiologists that are more familiar with these issues, are more attuned to issues of health equity. Again, not that there aren't wonderful white clinicians, but we know what the data says about the higher likelihood of having better health outcomes with Black and Brown physicians.
So that's sort of going outside of the standard of care as well. You wouldn't really go and put in a bare metal stent in someone when you know that drug-eluting stent is a metal scaffold that's coated with chemotherapy-like molecules to help prevent the body from attacking it and closing it down. The likelihood of those closing down compared to a bare metal stent that doesn't have that in there is less likely. You can look at that also in heart transplant. What's being evaluated and offered for heart transplant, advanced heart failure therapies, what's called left ventricular assist device, defibrillators. When we know someone has a heart function that's less than 35%, you're at higher risk of cardiovascular events and sudden death. And that's the standard of care, that we offer a defibrillator. But many times I see patients have a lot of social issues. So whether it's a nurse practitioner or a physician may just already write them off. Oh, they don't have a stable living environment. Oh, they don't have this, or they had drug use, or they did this, and wouldn't offer a defibrillator, making that solo judgment on someone's actual living environment.
And you're speaking to bias, and so I want to bring Chances Quillette back into the conversation, because as a patient, as someone that was really leaning upon the recommendation from a doctor that could have cost you your life, how does that land when you hear that that's something where a doctor that felt like, where Dr. Gigi's talking about a doctor that felt like, hey, I'm fair, and then he looked at the data, and then we're talking about how one doctor's decision could be the difference between life or death, and how does that land on you as a patient?
It's shocking and heart-wrenching, to say the least, because that was my experience. And after I had my heart attack and stroke, I took the accountability to fire all my doctors, and I wanted doctors that looked like me, that understood me culturally, that I could actually talk to, and let them know what was going on, and just be truly transparent. I didn't feel like that when I was talking to my other doctors. I felt like it was just, hey, it's all in your head, it's not that serious. But I potentially could have lost my life, and I'm glad I didn't. And now, the doctors, the cardiologists I have, the neurologists I have, they are, doing everything they can to make sure that, my quality of life is increased. And actually having doctors, normally you don't ever hear a doctor speak bad about another doctor. It just seems like there's just this code there. But my doctors were like, hey, these doctors were awful. It's likely that you're alive. Like, I'm looking at your charts, and, since 2013, I learned that, I had tricuspid regurgitations and myocardial regurgitations and murmurs that were already there, just had they done a heart cath. I didn't get a heart cath until 2019.
Mm-hmm.
And so, it's just scary. So I always tell people to advocate, if you don't like what the doctor is saying, then, find another doctor, but make them do their work. That's what insurance is for, and that's what you're paying them for. And that's what it took. It even took my husband saying, hey, she is not leaving this hospital until you guys can find out what is going on with her. She's just not having chest pains and jaw pain and all these different issues, and nothing just not wrong. And what my cardiologist told me is, like, the human body is like a car. And he's like, if that engine light comes on, there's something wrong, the transmission and whatever, but ultimately, it's getting ready to break down, and you have to find out what's going on before that happens. And so, yeah, it's, I talk to people all the time about this, but I know it's there. So
can I piggyback on that? I'm glad you advocated for yourself, but I always look at just being in Washington, D.C., we have several offices. And our downtown office is quite different from our Washington Hospital Center office. The downtown office, they have the lobbyists, the lawyers, the people that'll come in and say, my brother's a doctor, my cousin's a internist, and they demand stuff, right? So there are millions of people that have no idea of what to ask for and how to advocate for themselves. And that's where the physician is supposed to be there to help them out. My hospital center office, a lot of times, they come and say, okay, whatever you say, doc. Or, just try to figure it out. And they wholeheartedly accept what you say, whether it's good, bad, and different. And they can't just go and get another doctor. They're sort of stuck. Many of them are stuck with the clinic system in the district. They try to do their best, but they're stuck in that system. And so that's why I say it's bigger than just the people on this call, people like yourself, and, advocating for women's heart to get more people involved to really change that structure or the system to allow better access, better quality of care.
Well, and if I could just sort of, in remembering Reverend Dr. Martin Luther King Jr., when we're looking at health, it is about voting rights. It is about civil rights, because all those things impact the quality of care, the food, the housing, all of these important factors. I'd like to ask Dr. Bond a question about sort of what the target numbers for blood pressure are, because sometimes actually patients will come in and say, oh, I run high. Okay, this is where I'm at. Can you tell us what is a normal blood pressure? Because they keep changing also.
Yeah, so as Dr. Robinson very nicely explained what blood pressure is, it's also important to understand what normal numbers are. And when we think about a normal blood pressure, that really should be a systolic, meaning that top number 120, and diastolic, that bottom number over 80 or less. So 120 over 80 or less. When we go above 120 over 80, it's actually considered elevated. And it's not until we get to 130 over 80 when we actually are now in that high blood pressure, or what we in the medical field call hypertension stage. We actually about a few years ago changed and revamped our blood pressure guidelines to drop the level down by about 10 points of what is deemed high blood pressure, because what we began to notice was once we get to even above 120 over 80, we begin to see a higher risk of cardiovascular disease such as stroke, peripheral vascular disease, and heart attack. And once we get to that 130 over 80, that risk doubles. So for that reason, this is why it was dropped to have a high blood pressure defined as 130 over 80 or greater. And more importantly, we know that once you get to that range, a lot of times, depending on your risk, lifestyle can help us drop that level back down to a normal range. So including a healthy eating habit, exercise at least 150 minutes per week of some form of cardio, which does include walking at a brisk pace. But then there are situations where we now get into the second stage of high blood pressure, or we have a multitude of risks where we may need to consider the addition of medication. So the first and most important thing is making sure that you are getting your blood pressure checked at least on an annual basis by your internist or your primary care physician, whoever it may be.
So, you mentioned a lot there that I'd like to come back to. And, many people don't recognize that there may be other factors that contribute to high blood pressure. We tend to think about, I'll just name them. People don't realize that anti-inflammatory medications that they may be taking for their back pain or aches and pains, such as ibuprofen, Aleve, Motrin, aspirin, Advil, all of those can contribute. People also don't recognize that alcohol in all of its forms, beer, wine, or hard liquor, can push up blood pressure. But people also, one of the things that I try to educate my patients about is sleep apnea. Now, as somebody who has sleep apnea, what does that look like? It looks like fatigue, despite the fact that you may have gotten many hours of rest, and you wake up and you still don't feel refreshed. That, it turns out, is a risk factor for heart disease, for stroke, for dementia. That's the one that tends to get people's attention, that it's dementia, diabetes, as well as certain cancers. So we have to, and then actually my sister had very difficult to control blood pressure. She had to be on 4 or 5 medications. Turns out she had a very rare tumor, benign, not cancer, on top of her kidney and her adrenal gland that was secreting a hormone that was causing her blood pressure to go way up. When she had that removed, guess what? She's only on 1 blood pressure medication now. So I'd like to ask sort of our advocates here, where can people get information such as this to learn about what their particular risk factors are, and what are some of them that we can change? We obviously can't change our age, our gender, or our ethnic background or family history, but what are some of those reversible causes, and how can one get information about them?
Well, I can speak on behalf of at least the Association of Black Cardiologists. So I sit on our board of directors for the Association of Black Cardiologists, and I'm currently the co-chair of our Women and Children's Committee. We've done a phenomenal job in creating a 7 steps to heart health, and it's actually 7 steps that look specifically at 1, access. We talk a lot about making sure that we have uninterrupted care, follow through with our primary care physicians or cardiologists, whoever it may be. We also talk a lot about making sure that we're checking our blood pressure. So a big part of that is encouraging patients to consider getting an ambulatory blood pressure machine, something you can buy at any local pharmacy over the counter, and ensure that you bring that machine into your doctor's office to, 1, validate it to make sure it's working appropriately, but also check it at home to see that your numbers are exactly at the goal that it should be. We also want to make sure that we're checking our cholesterol levels. So this is another very common risk factor for heart disease, but it's something that we can typically modify, be it through lifestyle or in certain situations, medication. The same way we want to make sure that we're checking our blood sugar. We also want to encourage patients to not smoke, not drink alcohol in excess. You brought up a very key point that alcohol can drive up one's blood pressure. And as it stands, we know that any male really shouldn't be having more than 2 alcoholic beverages per day, a female more than 1 alcoholic beverage per day, if they do insist on having any form of alcohol. And beyond that, we want to make sure that you're eating smart, exercising. And what's different about the Association of Black Cardiologists 7 steps is that they also incorporate the fact that reduction of stress is key. And a big portion of that is also looking to our spiritual community. So the faith-based community, which we know our communities of color, more importantly, really, I think, receive a large, not only fund of knowledge from, but more importantly, support. And that's really what differentiates that. So this is an easy enough workbook that also includes suggestions as a cookbook as well for what would be healthy dieting, what would be changes in terms of what our food intake should and shouldn't be. And it's on the Association of Black Cardiologists website. And it definitely is something that I think would help our communities figure out how to prevent, again, heart disease. And I do think it's important that we acknowledge that heart disease is something we could prevent 80% of the time if we actually focus in on the blood pressure, the cholesterol, the blood sugar, the exercise, eating healthy, not smoking, not drinking in excess, and reducing that stress level for sure.
I'll just piggyback on obesity and smoking. When I tell people that smoking is the second leading cause of amputation, they look at me like I was crazy. No one's ever told them that. It's right behind diabetes as a number 2 cause of peripheral arterial disease, or you see people get gangrene and amputation. So you're likely to have a higher risk of developing peripheral arterial disease. When you look at our community and you think about obesity or being overweight, 2/3 of our folks are overweight and obese. And when you look at the extreme of obesity and what happens after gastric bypass, their blood pressure medications go away. And many times their diabetic medications go away many times. Sleep apnea gets better. So you don't want to have to tell people, oh, they need gastric bypass. It just tells you the impact on obesity, on all of those things, on hypertension, on high cholesterol, on diabetes, on your back, on your knees, all of those things that on inflammation of the body, causing a bigger risk factor for having bad outcomes with COVID if you're overweight and obese. So thinking about those things are key when you're looking at modifiable risk factors. I always tell people it's about TLC. And they're like, what is TLC? Total lifestyle change. Right. So no one on this call will go to Joe Schmo's gas station and put just any gas in their car. They're going to go to a specific gas station. They're going to put a particular gas in their car. They think more about their car than they do their body. I make that analogy that you're the Bentley. You can't go to Advanced Auto Part and get that new brain or that new heart or that new kidney. But people will never put diesel in a high-test car. Never. It would never cross your mind to do that. But why put the diesel in your body when you're thinking about that? That could be the cigarette. That could be, that fried chicken all the time. Or that could be a number of things that can impact.
Ms. Selena, what are some of the myths that you find are prevalent, and what are some of the myth-busting facts that you can share with us?
Well, I think that the number one myth that we find, not to disparage anything about the last panel you're on, but that the number one cause of death in women is breast cancer versus heart disease. And we are fighting that myth on a regular basis. Part of it is, I think, heart disease, because it's so ubiquitous, we kind of sort of push it to the side. And I think over the last several years, the medical community has done a really phenomenal job actually of increasing awareness around cancer and breast cancer in particular, where screenings are now a sort of a very regular and a common thing that women sort of go through. Heart disease doesn't have one single test that says you have heart disease or you don't have heart disease. We just described the multitude of ways that we can better understand what our risk is of heart disease, but it takes work. And so I think that myth is something that we are fighting every day. I think the second myth is that women, and this is what I've heard from women who've gone through it, that they think they're going through it alone. Women Heart is here to say for every woman, from whether it's Shanta Quillette or any other woman who has heart disease, you are not going through this alone. And it has a direct impact on lowering your stress when you can identify the community of women that you can go to and speak with about the experience, so that you can see. I've seen women work miracles for one another. A woman who is pre-op, who talks to another woman who is 10 years out from her operation, when she can see somebody and say, wow, I don't have to be afraid. There is hope. There is thriving after this procedure. That is powerful stuff. And we provide that opportunity for women to interact with each other like that on a regular basis.
Shanta Quillette, one of the things I've been hearing, and this is great, so I'm not disparaging it at all, but I'm saying there's a difference between theory and reality. I learned that a long time ago, right? And so the theory says eat right, exercise, TLC, total lifestyle change. How does that look like in real life? You experience it, right? So you had the heart attack, you had the stroke. How does that lifestyle change look, and how does that play out in real life? And how did you find the support to be able to make that lifestyle change to stay healthy and keep moving forward?
Well, I can definitely tell you it's a challenge, because if you've been doing something for so long, you've formed a habit, you have to break a habit. It's like, hey, I've been dedicated to Twinkies since 1997, and now I have to change. But it's just, it's really mindset and the willingness to live. I still have, challenges, but I do have some accountability. Once I had my stroke, I joined a program called Cardiac Fit, where there is a nurse practitioner there that I talk to on a weekly basis, that, makes sure that I'm monitoring my blood pressure, any changes in heart. Like, I was just recently was experiencing a racing heart every time I woke up in the morning. It didn't really at that time feel like it was something that was, an urgency. It's like, hey, I get up, I'm moving really fast, but then found out that I needed to take some medication to slow it down. And so having those conversations on a weekly basis, it helps a lot, making sure like, hey, what are you eating today? What have you eaten this week? And then also admitting that sometimes I have bad weeks, but, finding groups like Women Heart and the American Heart Association, which I've been, participating in and being really active with them and having those open conversations about, not only what you eat, but family history. It's not something you can change, but going back thinking, my mom had a mild heart attack and a stroke and didn't tell anybody. My dad had high cholesterol, high LDL levels. He's been on torvastatin for years, never told anybody. So these when I was going to the doctor and I'm filling out my check sheet and the doctor's like, hey, do you have any family history of this? And I'm like, no, I'm perfectly healthy. My dad's perfectly healthy. There's nothing going on. And then when I had my stroke, I had cousins reaching out like, hey, you need to go to a pulmonologist because, I experienced this. And so now, when we're talking about, what Aunt Bertha is doing, we talk about now, it's like, hey, we need to stop the gossip. We really need to have these conversations that can help generations, break these curses that, as a melanated person, we need to open up and discuss that. Hey, I'm going through these things. I found out it's genetic, and it can help the next person, because I do believe, even though my doctors, I don't believe they did the best job. But had I been able to say, hey, yeah, my dad has this, and my dad has cardiac arrhythmia, and my mother's had a heart attack and stroke, then the doctors could have looked a little bit deeper and said, hey, well, we need to look at that, because if that's something they've experienced, then it's more than likely you're experiencing too. So just having the accountability, having the open conversations, talking to other people, and letting people know that, don't be scared to go to the doctor. Don't be scared to be transparent about your eating habits. I'm a comedian. I talk about it all the time. My challenges with with food. It's like breaking up with a boyfriend, a toxic boyfriend. I gotta go back sometimes. So yeah, so it just
Well,
yeah,
and you know what? And you know what? During COVID, I mean, one of our panels is about mental health. I mean, look, I am an example of how food is self-soothing, right? So, but it is about making small changes that can be sustained. I'm going to shift gears a little bit and ask Doctors Bond and Robinson to weigh in on this. People in Black and Brown communities don't tend to be trained on CPR, and CPR can save lives, the chest compressions. There have been changes in the recommendations of people performing CPR, because it used to be that everyone was, I'm not going to do mouth-to-mouth resuscitation, that I just don't feel comfortable doing that. Can you please update us about what CPR is, and maybe tell us the 2 songs that we can remember that can keep the beat for chest compressions?
So the AHA has gone just hands-only CPR several years back. And actually, the BG Staying Alive was one of the main things that they did, is that tempo. The other thing is that when we talked earlier, Mrs. Gore, we talked about some of the legislative things that our Heart Association did, was making it a requirement for graduation in the DMV, DC, Maryland, Virginia. Before kids could graduate, they had to learn CPR, which could be, life-saving on its own, just getting a whole new crop of people getting CPR. I wanted to touch on something that Carter Williams mentioned, that she wakes up with a fast heartbeat. Dr. Gigi mentioned sleep apnea. So if you've never been evaluated for sleep apnea, you probably want to check with your primary physician or your cardiologist about getting evaluated for sleep apnea, especially if you want to make sure you're not missing atrial fibrillation with your family history of stroke as well on top of that.
Actually, I'm getting my CPAP machine. I actually I do have CPAP. I did find that out. Along with the medication that they put me on. So I know there's a back order on the machine that I need. But yes, there's that accountability. My neurologist is like, hey, let's check this out, and they found out that a lot of things going on. So, I really appreciate that now.
80% of the stuff that we deal with comes with talking to someone. So if your physician can't talk to you, they're missing half the vote. We just talked for a couple of seconds, and just being able to listen to the patient is important.
Dr. Bond?
Yeah, I was going to just say, to add to Dr. Robinson regarding CPR. So we're also seeing that in addition to communities of color less likely to be trained and feel comfortable utilizing it, we also know that bystanders are less likely to perform CPR on women. A lot of that has to do also with the comfort of the location as to where the hands would have to be placed. So from a local level, what a lot of organizations are working on is to try to make sure that those that are getting CPR training feel comfortable working with mannequins that are both male and female, just to ensure that they know where to place their hands. We know that CPR is life-saving when you started immediately. And as Dr. Robinson very nicely said, the vast majority of the time, all we need to do is hands only. So making sure that we're pressing hard, fast at a beat of about 100 beats per minute. But more importantly, we know that following a song like Staying Alive, I believe even Beyonce's song Crazy in Love has about that 120 beats per minute. If you wanted to change it up to a different generation. But it's life-saving, and we encourage everybody out there, if you yourself have not gotten training, please to do so, because you can absolutely save a life.
Yeah, I think
row your boat is another one, by the way. Row your boat. So,
Staying Alive has the greatest title in terms of CPR, and just because of what you're actually doing. But I think Crazy in Love is probably going to get people to stay on just a little bit longer, because that song is so much fun. So as we're wrapping up here, we've got about 5 minutes left. One thing I'm going to touch on with Dr. Bond real quick, and then we're going to let everybody talk about their organizations and how they can get in contact with. So one thing we did touch on today, Dr. Bond, is maternal mortality. And we're talking about all of these obesity, we're talking about all of these lifestyle changes we need to make, but we understand that Black women and women of color have a 2 to 3 times higher maternal mortality rate when it comes in. And so organizations like Blue Cross Blue Shield America, I interviewed their CEO, and they've made a significant pledge in order to try to lower that rate in Black and brown women. What can be done in order to lower the maternal mortality rate in Black and brown women? Or is it just something that, again, that we just kind of throw our hands up and say it happens?
Yeah, so that's such a loaded question, because it definitely has, I think, a multi-tier approach. When we think about why even myself as a cardiologist is so concerned about the rising maternal health crisis that we're seeing, the reason is that heart disease is the leading cause of death in pregnancy, as well as up to 1 year postpartum. And we know that when we think about the statistics, we see that about 1 in 3 deaths are due to cardiovascular disease. Unfortunately, though, although these deaths are 60% of the time preventable, they're not happening. And just looking at the death is really the iceberg, because for every death, there's about 75 to 100 complications that also could have been prevented, ranging from gestational diabetes or gestational hypertension, making sure, and what we really want to focus in on is making sure that women understand what their risks are before the pregnancy. So focusing in on preconception counseling. You ask the question, what can women do? That's the first step. Making sure that you talk to your physicians about, what are my risks? What does my risk look like for myself in terms of my conception? If I have high blood pressure, is my blood pressure under control? Should I be transitioned to medications that are safer to use during my conception? As an example, because not all blood pressure medications are safe when you are pregnant or breastfeeding, as an example. But beyond that, when we think about the top 4 risk factors for why we're seeing a rise in maternal mortality, especially in the Black and brown community, we know that hypertension is definitely up there, obesity is up there, age as a factor. Mothers now are having children later on in life, so as a result, that comes with slightly higher risks of complications. But the leading cause is race. And when we think about race, it's more of the social aspects of that race. Everything that Dr. Robinson very nicely alluded to, those social determinants of health, the access to healthy eating, the access to the ability to exercise in a safe location. But at the core of it is racism. And that's where organizations, even like myself at the Association of Black Cardiologists, we are trying to work, even from a policy perspective, to make sound structural changes at that level, that high system level where structural racism is at the core. I love the fact we highlighted that local physicians are even looking amongst themselves at their unconscious biases and making changes to that effect. We know that organizations are working to do such things, even from starting out in medical school, as an example. And I'm very proud to say that the Association of Black Cardiologists is doing just that by holding healthcare systems and other organizations accountable to say, what are your biases, be it conscious or unconscious, more commonly when it comes to healthcare. But I think until we dismantle the structural racism that we're seeing, we're going to still see these despairing numbers. But what we want to do as an organization is make sure that we provide our patients with the tools so they can advocate for themselves and make sure that their voices are being listened to in this crisis that we're seeing.
Absolutely. All right. So lightning round. Let's kind of talk about your organization. How can people get in contact with you? We'll start with you, Shanta Collette.
Yeah, so I'm Chandra Collette, of course. I have two organizations, the Pink Peppermint Project. We focus on women with metastatic breast cancer. We provide programs and resources. You can reach me at pinkpeppermintcares.org. So I also have a consumer goods company that focuses on vegan products for women who are going through premenopause like myself, and that is thriveinnovations.com. So I look forward to, seeing you all in the future.
Absolutely. Selena.
You can come to womenheart.org to learn more about us as an organization. If you are a woman yourself dealing with heart disease, if you are a woman who is ready to help other women, come and become one of our champions. If you are a healthcare practitioner, you can refer women to womenheart.org. And if you are a hospital, you can join our National Hospital Alliance to demonstrate that you are committed to women with heart disease.
And Dr. Bond, I know give a shout out to the Association of Black Cardiologists.
Yes, and if you would like to get any information, their website is abcardio.org. You can also follow myself on any of the social media networks at Dr. Rachel M. as in Marie Bond.
And Dr. Robinson.
You can look under MedStar Health or medstar.org and heart.org to get a ton of different information on cardiovascular health, as well as downloading their app, the American Heart Association app.
Absolutely. Well, I want to thank you all again for this. This has been a wonderful discussion. Thank you, Shanta Collette, Selena, Dr. Bond, Dr. Robinson, of course, Dr. Gigi, and the Rodham Institute at George Washington for being a wonderful partner throughout the day. But this is a wonderful panel to talk about heart health because it connects to everything. It connects to your sugar, to your hypertension, to everything that you're doing. It connects to all of that. Your diet is going to determine a lot about your heart health, and it is preventable. I think we heard earlier it's 80% preventable. So do what you need to do. Move, eat right, get a right amount of sleep, and reduce your stress. Those 4 things right there will go a long way towards keeping your heart healthy and giving you a long, healthy life. So thank you all again. We're moving on to the next panel. Next up, we're going to talk about health in a Black family. So we're going to talk about eating right and obesity and all those things that we just talked about. We're going to have on our next panel. So join us in a few minutes.
All right.
Thank
Take care.
you.
Thank you. Thank you.